I wanted to ask Dr. Krakow, is the cheapest agent that blocks renin, the renin-aldosterone system, the best? Would you just use whatever the cheapest? Or do you have a special preference?
I'd hate to be quoted on the cheapest, but the generic ACE inhibitors, there are a number of generic ACE inhibitors, and some of them have been studied in trials, like enalapril and lisinopril, which is in this last one, ramipril altase, which was in the HOPE trial. So there are a number of ACE inhibitors that are generic. I think the prices vary for reasons that certainly I can't imagine an explanation. But one likes to use once a day, so ramipril and lisinopril are long-acting. Their prices, I think, are reasonable, and the formularies may have a preference, and of course that, but they're among ACE inhibitors of the same duration of action. They're all very, very similar in terms of effect on blood pressure, side effects profile, cough, and the rare angioneurotic edema. So it's a good bet. And 10% of patients on ACE inhibitors will develop a cough. The ARBs are available. But I think this has been a major advance in cost-effective medicine now that they have become generic.
Wow. That's very good news. Dr. Poretsky, do you ever use nutritional supplements, and what do you think of them for treatment of PCOS?
I can actually see that card here, and it lists these supplements. But I don't think there's any good evidence for effectiveness of any of these. L-cysteine, omega-3, vitamin D, something acid, chlorogenic acid.
Chlorogenic acid?
Chlorogenic acid, and low glycemic index diet. So vitamin D is interesting because everybody uses it for everything now. We just in fact started, we're one of the centers in a big NIH trial that looks at whether diabetes can be prevented with vitamin D. But as of now, there's no evidence that vitamin D intervention will do anything for PCOS as far as I know. Low glycemic index diets is a very controversial area, including what low glycemic index really means. But I'm not aware of any evidence that it makes a difference in PCOS.
Thank you. Dr. Smith, I forgot one of the questions, probably because statins induce memory loss. What is your comment?
It's rare, but it does happen. I had a concert pianist came in, started statin, suddenly lost her repertoire. Horrible. So she stopped, and it came right back again. I've had some professors here who've come to me who've suddenly said, I'm not thinking quite as well as I was, and stopped it and did very well. So these are things that you see extraordinary, maybe twice in 25 years. So it is not common. The partner will always find it. They will see it immediately if it happens. So all your 60 and 70-year-olds who are forgetting names, losing things as they sit in their hand, forget what they went into, that is not a statin problem.
And would you say this is something you see immediately? You don't see this over time?
Yes, right.
Okay.
So just reassure, that steady loss is it has nothing to do with statin.
And pursuant to that, the first question that my patients usually ask is, am I going to lose my memory? The second question is, are you going to give me diabetes by giving me a statin?
Yes, okay. So if you look in the Women's Health Initiative and look at the people who use statins and look, I can't remember, 3-5 years later, there was a higher percentage with the diagnosis. Now, they're not measuring glucoses, they're not measuring hemoglobin A1Cs, but the Jupiter trial gives a lot of information on that. And what they showed was if you don't have any of the metabolic syndrome characteristics, you will not move into a diabetic category. But if your glucose fasting is up in the 115 to 120, 122 range, yes, you'll take a statin and it now will be 128 and you'll have diabetes. So that is what we mean by new diagnosis of diabetes. It does move glucoses higher. So the chance of that, and I use this, is 1 in 300 cases, 1 in 300 per year for that. Okay, so that's what I use. But yes, it is a phenomenon. It's a very tiny phenomenon, but you have to be able to reassure patients so they won't take it.
Thank you. Dr. Krakow, a question from the world of obstetrics and gynecology. Patient with preeclampsia, would you recommend strict blood pressure control? And if so, with what agent? Let's say somebody wants to get pregnant. What agents would you be using?
Well, during the obstetric episode, neonatologist, high-risk obstetricians manage these patients, I think, very, very well. We collaborate, but in their view, I think for the most part, the safe drugs in lowering blood pressure that are effective are labetalol is probably number 1, and the calcium blockers number 2. Diuretics, which used to, when I grew up, they were very popular because of the edema, so everybody with edema should get a diuretic. Those are out because of risk. And the renin blocking system, there's definite evidence for fetal damage, so they're out. I'm talking about during the pregnancy. Now, I do see, and I suppose we all do, young women who are hypertensive need to be treated. They've been worked up, and the best management is antihypertensive medication. And then the question must be asked is, are you planning to become pregnant? And that should be really part of our absolute checklist and not forget it. Because the counseling then involves making them aware of if they have been hypertensive and had a previously hypertensive pregnancy, the risk of that happening again and progressing to sustained hypertension, and the drugs that if they're beautifully controlled on, let's say, an ACE inhibitor alone or an ACE inhibitor and low-dose diuretic, they can't continue that, and when to stop, when they become pregnant or when they're planning a pregnancy and likely to be one. But the counseling is crucial, and collaborating with a high-risk obstetrician so the patient really gets the team that is needed. After pregnancy, and most of the time the blood pressure does come down to normal. If there's any doubt, some of them have a little white coat hypertension, and we monitor them at home or with ambulatory monitoring. And then we basically follow them very closely to see if their blood pressure is drifting upward, probably more closely than we might someone else. But that's, I think, you need a strategy and a team, I think, is crucial.
Dr. Poretsky, there are 2 questions here that ask about environmental factors in developing PCOS, environmental other than nutrition. Toxins, things like that. BPA, anything of note in that regard?
No, I don't think so. That's simple.
Okay. Dr. Smith, is there a point in measuring a particle count? And how do you use it?
So the reason that particle counts have become used is because when you have the higher triglycerides and the lower HDL, especially in diabetics with dyslipidemias, the particle numbers far exceed if you look by percentile in the population. That is, what is the LDL of 130 is about the 50th percentile. What would be the NMR particle number? It would be 1,300. So you divide by 10, and you can make a calculation to see whether the particle numbers are much relatively higher, elevated, than what you're getting back for the LDL cholesterol. I used to use this more, especially in people who are coming in with the second heart attack. You've been doing preventive stuff, and all of a sudden, bang, they're back again, and you want to see if there's anything that's, then you can use them in that. I'm using it less now. Because of these trials and the use of non-HDL, I'm really sort of counting on that. It's a much simpler for me way to explain things to the patients and to figure out. ApoB is another particle measure. So if you want to use 70, 100, and the VAP basically will give an APO. If you go to LabCorp, they'll get you an NMR lipoprofile, which is the particle number. If you go to VAP, they will give, if you go to Quest, they will give you a VAP, which will give you a calculated ApoB. So the ApoBs that are equivalent to 70, 100, 130, and 160 are 65, 85, 105, and 125. Now, if you can't remember this in your head, it's worthless to get them because you don't know quite what to do with them, and they can become very confusing, not only to you, but to the patient. So if you want something, I would suggest that you just focus on non-HDL. I think you'll find that extraordinarily simplifying for your own therapeutic decision.
Thank you. I already have forgotten the correlations.
Stop the statin.
Stop the statin. Dr. Poretsky, what would you do for a lean patient with PCOS and hirsutism and menstrual irregularity?
So again, you really have to find out not so much what I would do, but what the patient really wants. What is bothering her the most? Menstrual irregularities is interesting. Some women think that they really must have a period every month. Now, if you look at how this really developed over time, it's really sort of a myth that a woman must have a period every month. Before birth control pills, most women, once they go into puberty, would get pregnant, so there are no periods for a while. Then they breastfeed, there's no periods. Then they may stop breastfeeding and may have 1 or 2 periods, and then they get pregnant again, and the cycle repeats. So throughout this history, there were really not that many periods that women of reproductive age had. Now, however, yes, normally, if there's no pregnancy, there would be a period usually every month or so, but it doesn't have to be that way. So women can be reassured that if they have 3 or 4 periods a year, that's probably sufficient. The main goal is to shed the endometrium, because women with PCOS do have increased risk of endometrial cancer because their estrogen levels are high. Because estrogen levels are high because androgens are high, and that's the precursor of estrogens. But if they have, say, 4 periods a year, that's sufficient. However, if they still want to have monthly periods, although of course these are anovulatory bleedings, they're not real periods, then birth control pills is your best choice and maybe the only choice. Now, for hirsutism, anti-androgens, and particularly a combination of spironolactone, we start with spironolactone alone, and then we can add finasteride if that alone is not sufficient. So it's really symptom-driven, the treatment choice.
And building on this question, I'm sorry, it's building on this. Let's say this young lady wants to actually get pregnant and is not so excited about taking spironolactone and finasteride for her hirsutism. Is there anything that she can do?
So the first thing she should do is stop birth control pills. That has to happen. We have to remind her of that if that's the treatment that she's been on. And then when these women become pregnant, I would say my suggestion to them is as much as possible to forget about any other symptoms they have, just to get pregnant, get through pregnancy, and then deal with hirsutism or any other symptoms after pregnancy. It's just too important, and it's in there's a limited period of time during which they have to live with these and some other symptoms of pregnancy.
Thank you. Dr. Smith, I get asked a lot about, and we get asked a lot about, I would say a third of these cards are about muscle aches and statin myopathy. Any recommendations? Do nutritional supplements help? What helps?
So there is a genetic component to this, and that it has to do with organic anion transporter into the liver. We don't know why it's associated with this, but that's been found in some of the studies as the only gene. Myalgias occur in about 10% of people who are on these. They are mainly, if you ask if people get muscle aches and you're trying to figure out is this statin or non-statin related, they are in the lower extremities, and they often occur at night. That would be the most specific thing targeting a statin as the cause. What you generally do is you simply have a person stop and see whether they get better. There's no harm in stopping a statin for 2 or 3 months, seeing what happens. Some people will get within a day or two, they'll just get over it. Some people take much longer. Once you do that, and you and they are fairly certain that it was related, then you can go to another statin. There are some studies now that you can go back to the same one, and a large percentage of those people will be able to tolerate it for some reason now. Another way to do is just the 3 statins, which you can use on an other day basis and have a half-life that you can do that, are the newer ones. So it would be Crestor and Lipitor. If you go to simvastatin, the half-life is just in 5 to 7 hours. It will not last through. Lescol XL80, the weakest of all the statins, when put as XL, is equivalent to atorvastatin 10. It has the least myalgic problems associated with it. So you can use that 3 times a week, basically Monday, Wednesday, and Friday. Then usually you may have to add another medication, such as ezetimibe. And there's a question, do I use this at all? Is there any? And I would say, I told you about that trial in which they randomized you to 70 and you to 100, and some got there with a statin and some got there with Zetia and a statin, and they got the same result. I still think the LDL hypothesis, you lower the LDL, you're going to get reduction in events works no matter what you use. And it's now transposed to the non-HDL. If you lower that enough, then you're going to have a decrease in events. So yes, in statin myalgic patients, you can't get very far if you're just stuck with an every other day statin. So you have to use either the Welchol or one of the bile acid binders or the Zetia added on to those.
And I think we have time for one last question, and then we are ready for coffee and cookies, very fittingly for a diabetes symposium. And since we are talking about cookies, it has to be about lipids. Is HDL no longer a valid treatment goal? Should we no longer be raising our HDLs?
Well, the thing that said we need to get HDL greater than 40 was the TNT trial, in which they did a sub-analysis, and those people who were over 40 did better than anybody who was less than 40. So I used that. But then what I found is it's hard to get those HDLs up in everybody, and you're frustrated, they're frustrated. That's why I use non-HDL. If the HDL is 35, but the non-HDL is less than 100, there is no point in giving a niacin just to raise that. So that's why the non-HDL is so helpful for me. I'm reassured that people who are with coronary disease and the non-HDL is 100, unless I can get it down 60 more points with something, forget it, even though if their HDL is low. So that has reassured me that you don't have to push to get an HDL above 40.
Well, thank you very much, and I feel reassured now to eat my cookie. Thank you.